You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 10th, 2024. This week, I'll do an Inclisiran update, how dangerous are sodium channel blocking antiarrhythmic drugs, analytic flexibility in studies, the workup of patients with heart failure, and blood pressure in older patients. First, some reader feedback on Inclisiran. Last week, I discussed this drug, a small interfering RNA that inhibits PCSK9 production. The trial I discussed was Victorian and Initiate, and it was an RCT of using Inclisiran to get to a goal LDL cholesterol. This was clearly a marketing disguised as science trial. I bemoan the fact that the drug gained FDA approval without a cardiovascular outcomes trial. But many listeners wrote in to tell me about Orion 4, a 15,000 patient trial of Inclisiran versus placebo in patients with established heart disease and a primary MACE, major adverse cardiac events outcome. Now, the trial was delayed a bit during the pandemic and is scheduled to conclude in 2026. Okay, I really appreciate the information, but I am still perplexed why results of such a trial doesn't precede approval. I mean, what if Orion 4 has no effect on MACE? What if there is harm from Inclisiran? Now, both of these outcomes are unlikely, but there will have been many years for the drug company to market and build therapeutic momentum. Okay, another comment centered on cost. Dr. John Cooper writes in with another important fact about Inclisiran. In the UK, Inclisiran sells for approximately $60 an injection to the NHS, and this is the reason that NICE is recommending it in preference to other expensive PCSK9 antibody treatments. What I will now say seems too obvious to even waste words and time on. Cost is a major factor in translating evidence. Many therapies in cardiology would be much easier to use if they cost as much as generic metoprolol or lisinopril. Take ARNI drugs or SGLT2 inhibitors in heart failure with preserved ejection fraction. These drugs probably exert some mildly positive effect on average in patients like those in the trials. But when they add many hundreds of dollars per month to the average patient who's already taking 10 other drugs, it's hard to justify given this small incremental benefit. Inclisiran and PCSK9 inhibitors and bempedoic acid may have some small incremental benefit in addition to statin drugs in patients with severe vascular disease. But the typical American patient already pays hundreds of dollars per month for other drugs. So again, it's hard to justify adding more cost to an already fixed budget for an absolute risk reduction of, say, 1 to 2% in non-fatal outcomes over 5 years. So I find it easier to add therapies with modest effect sizes when they're at NHS prices. And I say thanks for the feedback. Keep it up. All right, first topic today is sodium channel antiarrhythmic drugs. On the April 5th podcast, I discussed a small series from the University of Pennsylvania group in which they reported on 34 patients who had non-ischemic cardiomyopathy, high-burden PVCs, and a backup ICD. And they reported that the dreaded type 1C sodium channel antiarrhythmic drugs, flecainide and propafenone, actually worked to suppress PVCs, and not only did they not cause proarrhythmia, but they actually increased the ejection fraction in many cases. That's, of course, because they suppressed the PVCs. I used that paper to launch into one of the biggest mistakes we have made in electrophysiology, and that is the misinterpretation of the CAST trial. CAST trial reversed the use of 1C antiarrhythmic drugs in post-MI patients who had PVCs. There was major harm noted in CAST. The number needed to kill was 29, and this induced regulators to put a black box warning on flecainide and proscribe its use in patients with any degree of structural heart disease. Now, I pointed you all to a great editorial on this by Beth Israel authors discussing this issue, and I'll link to it again. Well, this week, the journal Europace has published another study supporting the safety of 1C antiarrhythmic drugs when used carefully and wisely. This was a post-hoc analysis from the famous EAST-AF-NET-6 trial of early rhythm control versus standard care in patients who had newly diagnosed AF. Recall that the EAST trial showed a reduction in MACE outcomes from early rhythm control, though I have many criticisms of that finding. Recall also that EAST was not an ablation trial. Less than 1 in 5 patients randomized to early rhythm control in the EAST trial received an AF ablation. Early rhythm control was done mostly with antiarrhythmic drugs. This post-hoc analysis, first author Andreas Rillig set out to describe outcomes in EAST patients who were taking sodium channel blocking drugs in patients with and without established heart disease. By the way, this is a good use of observational data from an RCT, as long as it's not overinterpreted. Let's see what they did and what they said. Now first, recall that EAST randomized patients with AFib to an early rhythm control strategy or standard of care. Early rhythm control was not randomized, it was doctor's choice. The protocol discouraged use of sodium channel blockers, flecainide and propafenone, in patients who had reduced ejection fraction, and they recommend stopping the sodium channel blockers if the QRS was widened. In other words, they were careful. The primary endpoint of EAST was a composite of CV death, stroke, heart failure, or ACS. And there was a safety outcome as well, including an adverse event related to antiarrhythmic drug outcome. There were about 1,400 patients in the early rhythm control arm. About half of them were using a sodium channel blocker and half were not. These two groups formed the focus of this observational analysis, basically sodium channel blockers versus sodium channel blockers not or never. Now, results. There were baseline differences, as you'd expect. Patients treated with sodium channel blockers on average were younger, more often female, and less often had structural heart disease. Sodium channel blocker patients also had a lower CHA2DS2-VASc score, but there were no differences in the use of oral anticoagulation. One interesting descriptive finding was that the number of patients with sinus rhythm did not differ on or not on sodium channel blockers. So the drugs weren't any more or less effective than other antiarrhythmic drugs. Most patients on sodium channel blockers had no heart failure, but of the 177 of 700 patients on sodium channel blockers with heart failure, 2% had HFrEF, 21% had heart failure with mildly reduced ejection fraction, and 77% had HFpEF. During the trial, no relevant changes were noted in EF, nor was there any worsening of heart failure class on patients who took sodium channel blockers. Here are the efficacy and safety outcomes. Early rhythm control patients on sodium channel blockers had 45% fewer primary outcome events than early rhythm control patients not on sodium channel blockers. It was 3% versus 4.9%. Patients on sodium channel blockers also spent fewer nights in the hospital, and that was a second co-primary endpoint of EAST. The primary safety endpoint, which was death, stroke, or serious adverse event related to rhythm control, also occurred numerically less often in the early rhythm control arm on the sodium channel blockers, though it did not reach statistical significance. In serious adverse events related to rhythm control, this did not differ between the sodium channel blocker or no sodium channel blocker group. In the subgroup of patients with coronary artery disease, stable heart failure, or LVH, there were also no differences in safety outcomes in the sodium channel blocker or no sodium channel blocker arms. So my comments. Similar to the UPenn case series, these observations also suggest that 1C drugs, flecainide and propafenone, can be used safely. The massive caveat here, though, is that these reassuring outcomes were obtained within the confines of a randomized trial that had strict protocols and careful use. Another caveat is that although this data was derived from an RCT, this data is observational. Doctors, not randomization, chose the patients who were put on sodium channel blockers. In the discussion section of the paper, the East authors cite other observational data which also report no increases in adverse events in patients treated with 1C drugs. Again, observational data means that a doctor chose which patients to use these drugs on. The authors also discuss the differences in East patients and those in CAST. The CAST trial studied sodium channel blockers in post-MI patients who had LV dysfunction. Sub-analyses of CAST had suggested that the greatest risk from the antiarrhythmic drugs were in patients with ongoing ischemia, and these patients, of course, were excluded from the East trial. So I agree with the authors that the black box warning on flecainide and proscription of its use in patients with any structural heart disease is way too aggressive of a recommendation. Such a proclamation and our current practice pattern goes too far and is an example of incorrect use of evidence-based medicine. For instance, I have cared for many patients who have revascularized coronary disease and normal LV function who have taken propafenone and flecainide and done well. And of course, I put in their chart full of notes saying that the patient understands that this goes against current practice patterns, but it's working for them. Now, I don't want to give the listeners the impression that I love antiarrhythmic drugs. I don't. The older I get, the less I use antiarrhythmic drugs. But they do have a role. Sodium channel blockers are especially good at suppressing short episodes of PAF and patients who have frequent atrial ectopy. My final comment on this paper, I want to close with a serious warning. Sodium channel blockers need to be used with extreme caution. They can cause life-threatening adverse events such as proarrhythmia from 1-to-1 atrial flutter and ventricular tachycardia. It is crucial to watch for QRS widening. Propafenone metabolism is highly genetically variable. The drug should also be used with beta blockade so as to prevent the 1-to-1 flutter. And what's more, sodium channel blockade by definition, right? Basic action potential physiology, these drugs are negative onotropes. So sodium channel blockers can exacerbate LV dysfunction, and I say be careful. All right, second topic is on the matter of analytic flexibility. Now, I don't think I've ever covered a paper from the Journal of Clinical Epidemiology. This week is the first, and it's one of the most important papers I will cover this year, seriously. The paper deals with how authors analyze data. Consider that when you read a study in a journal, the authors say in the statistics section that they analyze the data in this or that way. The key is that it is one way. But it turns out, especially for observational studies, there are many ways that they could have analyzed the data. Dr. Dina Zaratker and colleagues from McMaster University actually showed that there are more than quadrillion choices on how to analyze data of a typical observational study. I kid you not. When you add up all the choices and combinations of covariates and potential statistical models, there are almost an infinite number of ways to analyze the data. And it turns out it matters. Here's what the McMaster's team did. They chose the topic of red meat consumption and mortality. They first used the best systematic review on the topic. Well, within that systematic review, there were 15 studies and about 70 unique analytic methods depicted. Now, recall that all these papers that got into the systematic review were first published and made it through peer review, and all of these analytic methods were felt to be reasonable. The McMaster's team then made a list of all the different covariates in the systematic review and all the different analytic methods, and they came up with a quadrillion different ways of combining these choices. They took a random sample of these and they came up with about 1,400 different ways to analyze this different data set on red meat and mortality. The different data set that they chose was now an NHANES data set. They called each analytic method a specification. 200 of the specifications turned out to have implausibly large confidence intervals, and they excluded that. That left them with 1,200 specifications, which is actually 1,200 different ways to analyze the data from this NHANES data set. Okay, on red meat and mortality, their median hazard ratio of the 1,200 different ways was 0.94, and the IQR, or the confidence intervals, went from 0.83 to 1.05 for the effect of red meat on all-cause mortality, so this was not a significant finding. The range of hazard ratios was large. They went from 0.51, a 49% improvement in mortality with red meat, to 1.75, a 75% increase in mortality. And of all the specifications, about a third yielded hazard ratios more than 1, and 2/3 yielded hazard ratios less than 1. As for significance at the p-value of 0.05, only 4%, or 48 specifications, were statistically significant. And of these 48, 40 indicated that red meat consumption reduced death, and 8 indicated red meat led to increased death. Now, take a step back here and think about this. Notice here that about 5% of the analyses yielded significant results, and that's what you'd expect when you analyze data that has no effect. Nearly half of the specification yielded unexciting point estimates of hazard ratios between 0.90 and 1.10. So my comments, I'm going to link to this paper. I have a column coming on the heart.org on the matter of how analytic choices can affect outcomes. Recall that a few years ago, I reported on a paper from Brian Nosek's group in Virginia. They did the famous experiment wherein 29 teams of statistics experts analyzed a data set on European soccer leagues. The question was, did players with dark skin receive more red cards? Well, similar to this McMaster study group, Nosek found that different experts chose different ways to analyze the data, and about 2/3 found a significant association and 1/3 found no significant association. To me, and I hope to you, these are shocking revelations. I had no idea that the choice made by authors on how to analyze data could make that much difference in the results and conclusions. What this implicates is that every time you read an observational study that finds X or Y, you should be asking, oh, I wonder how this finding would hold up to a specification curve analysis, which is also called a multiverse analysis. So if you're reading a result in a journal, it's likely a positive one. But is this positive result one of the outliers? Would 1,000 different analysis and analytic choices deliver the same positive finding? Maybe yes, maybe not. I spoke with Dr. Zeneker, and she told me that multiverse analyses were not super hard to do. The biggest impediment was not the computing power, she said, but the feeling among experts that they know the best way to analyze data. Which is funny, since she estimated that there were 10 quadrillion analytic choices in her observational analysis of red meat and mortality. Okay, next topic, the workup of patients with heart failure. A paper from UCSF researchers, first author Matthew Durstenfeld, has brought up the issue of how to work up patients who present to the hospital with heart failure. The algorithm, the therapeutic fashion, says go to the cath lab to assess for coronary disease because revascularization will clearly help improve ventricular function if there is significant disease. And in the old model of cardiology, wherein most cardiac disease stems from clogged pipes, this strategy makes sense. For instance, the STITCH trial of CABG versus medical therapy in patients with ischemic left ventricular dysfunction and severe coronary disease showed a small survival advantage to surgery at 10 years, though the primary analysis of STITCH at 5 years was not significant. But then we had the revived BCIS-2 trial, which randomized patients with left ventricular dysfunction and coronary disease amenable to PCI and viability to revascularization versus simple tablets. And there were no differences in outcomes and no improvement in LV function when severe coronary disease was stented. Revive, to me, is one of the most important and most surprising trials of the last decade. It's just shocking to me that PCI in these near-perfect patients for PCI did not beat simple tablets, but it didn't. Well, the UCSF team was interested in a slightly different population of patients, those with any sort of heart failure, HFrEF or HFpEF, And of course, UCSF General Hospital is a safety net hospital serving patients with less access to health care. Now, they did not use a randomized design. Instead, they performed an observational look-back type study over a decade, studying the association between having a coronary assessment within a month after a heart failure diagnosis and death, or not having the coronary assessment. They wrote that they used a target trial emulation approach, which, as the name implies, attempts to emulate randomization. For instance, target trial emulation can take advantage of variations in practice, as well as they can perform careful propensity matching so as to make the groups as similar as possible. Then they can also do sensitivity analysis after the fact to assess the robustness of the findings. For instance, you can do the analysis again with different choices. See the previous topic I just talked about. They also can do falsification analysis, wherein they look at causes of death that would not associate with coronary assessments, such as MVA. In the end, they have two groups, those who had coronary assessment and those who did not. About 4,000 patients had coronary assessment, 11,000 did not. Now, there were many differences in baseline characteristics. Their first analysis was to show that baseline characteristics associated with the chance of having a coronary assessment. And kind of importantly, they found that women, older individuals, and those with documented unstable housing were less likely to have coronary assessment. These patterns were not explained by coronary risk. For example, diabetes and HIV were associated with lower odds of testing, even accounting for chronic kidney disease. Now, the next step was matching in target trial emulation. And of those 4,000 and 11,000 patients, they ended up with a group of 627 patients who had coronary assessment, and they were matched with about 5,300 who did not. And mortality was lower in those who had coronary assessment, 16% lower, hazard ratio 0.84 with confidence intervals from 0.72 to 0.97. Patients who had coronary assessment also had higher use of GDMT. Patients who had coronaries assessed were 7 times more likely to have revascularization, of course. And mortality with revascularization was 12% lower in the assessment arm, though this difference did not meet statistical significance. And the authors made 3 conclusions. They wrote in their abstract, in a safety net population, disparities in coronary assessment after heart failure diagnosis are not fully explained by coronary disease risk factors. Early coronary assessment was associated with improved heart failure outcomes, possibly related to higher rates of revascularization and guideline-directed medical therapy. And the third conclusion is the most important one, but with low certainty that this finding is not attributable to unmeasured confounding. Now, my comments. You already know what I will say. The authors made a gallant effort to emulate a trial, but it is still an observational analysis of 600 patients who got assessment and more than 5,000 that did not. I laud them in the highest way for stating that clearly in their conclusions. Low certainty that this finding is not attributable to unmeasured confounding ought to be a smart phrase added to almost every observational study manuscript in all of biomedicine. Now, they used ICD codes and electronic health records. There's almost surely confounding factors between the two groups. As they point out in the limitations section, patients who have a coronary assessment are more likely to follow up as outpatients. That's just one confounding factor. Now, proponents of the clogged pipe theory could say, come on, Mandrola, 7 times more revascularization, that's what drove the better outcomes. But I could also argue it was the higher rates of GDMT, or just the fact that younger patients with less diabetes, i.e. healthier patients, get the assessment. I could also argue that specification curve analysis, multiverse analysis of this data, might yield many analyses showing a null association. The UCSF team used one analytic method. What if they had used 1,000 different analytic methods? The best way to work up patients with this most common diagnosis in all of hospital cardiology, which is heart failure, is an important question. With the negative results of the revived BCIS-2 trial as background, I think there's equipoise. The way to answer the question in all comers with heart failure is not to look back with observational methods, but to randomize these patients, then follow them. Now, this sort of thing is happening in many clinical scenarios in Denmark, where there is a culture of randomization, but it's not so much in the U.S. So my main conclusion from this work is that the next major advance in cardiology might be a way to organize a randomization network wherein patients with uncertain approaches are randomized to one or another strategy, and then we would know. All right, final topic, a short one, systolic blood pressure in very old patients. The journal Circulation has published a provocative observational analysis which goes against one of my most common frustrations, and that is overtreatment and iatrogenic harm in the elderly. First, my frustration. As an EP doctor, I see lots of older patients because, of course, they get atrial fib. In my almost 3 decades of practice, one of the things that bothers me most is when overexuberance harms older people. And blood pressure therapy is a common issue. I constantly say the purpose of blood pressure treatment is to get old. We treat high blood pressure in 40 to 50-year-olds so they make it to 80 or 90 years. When they get to 80 or 90, they have won. And our job is not to give back the win. Yet we so often do. In our misapplication of like the SPRINT trial, for instance, we sometimes continue to shoot for systolic blood pressure less than 130. Some patients tolerate that, but what do you think happens when an older patient gets AFib or a viral infection? They stand up and then go boom. And that fall lands them in the hospital with a broken femur, and you know where that leads. And this is why this paper in Circulation deserves attention. The first author is Dr. Bernhard Hering. This is a scary paper. The German-led team looked at data from the Women's Health Initiative. They wanted to study the relationship between systolic blood pressure and longevity. The specific question is which systolic blood pressure level in older women had the highest probability of survival to 90 years. Now recall that the Women's Health Initiative was a famous study that overturned the practice of hormone replacement therapy in postmenopausal women for the reduction of CV outcomes, because actually hormone replacement therapy actually increased cardiovascular outcomes. Now, the German group had a population of about 16,000 patients who were enrolled in the Women's Health Initiative and were eligible to survive to 90 years before 2020. Importantly, they excluded women with competing risks, such as cancer, cardiovascular disease, stroke, heart failure, or diabetes. And my friends, this is key. They measured blood pressure way back in baseline, 1993 to 1998. Then it was measured every year until 2005. So the outcome of interest was survival until 90 years. They then measured the probability of surviving to 90 for all combinations of systolic blood pressure. And this was about a 20-year study. About 60% of the patients in Women's Health Initiative made it to 90, which speaks to healthier patients getting enrolled in trials, especially this trial. And their main finding was that women with a systolic blood pressure between 110 and 130 at ages 65, 70, 75, and 80 had a 38, 54, 66, and 75% absolute probability to survive to 90 years. They then separated the women into groups based on systolic blood pressure. There were like 5 groups. Less than 110, 110 to 130, 130 to 139, 140 to 159, and greater than 160. And then they made curves of survival. The probability of surviving to 90 years of age was lowest for the greater systolic blood pressure levels. The best survival hovered around 100 to 110 systolic. Their figure 2 shows the absolute probability of patients also who are taking blood pressure medicines. Now the patterns for these patients are about the same, though the absolute probability of making it to 90 was lower for all curves, and the greatest probability in patients who took meds was about 120, though it wasn't that much different at 140, so these curves are pretty flat. The authors concluded for women greater than 65 years of age with low cardiovascular disease and other chronic disease risk, a systolic blood pressure less than 130 was found to be associated with longevity. These findings reinforce current guidelines targeting a systolic blood pressure less than 130 in older women. And my comment is this is dangerous. First, this is an observational study, and unlike what the authors conclude, it does not support treating to target. Patients who had blood pressure that low are surely healthier and it is those factors, not necessarily the meds, that drove better chances for survival. Second comment, the exclusion factors should have made it into the main abstract. They took out nearly every vulnerable woman. The population they studied had no other significant diseases, but that is not often recognized in practice. If you are treating an elderly, frail woman with cancer and other comorbidities to a systolic blood pressure of 120, I would say that you fail medicine 101 and common sense 101. Please don't do that. Please be careful with older patients. Older patients deserve our greatest caution. 2 times old is still old. Most of the blood pressure trials, cholesterol treatment trials, all primary prevention trials were done in younger patients. Older patients have higher risk from therapy. And this study finds exactly what you would expect. If you have no comorbid conditions and are not frail, and you have been gifted great blood pressure, you are more likely to live to 90. It's survivorship bias on steroids. This study should never be translated to we can create the same scenario with 2, 3, or 4 antihypertensive meds. My thesis that elderly patients incur more harm from low blood pressure than high blood pressure still holds, and I wish the circulation editors had made the authors be more careful in their conclusions. So that's it for this week in cardiology. As always, I'm grateful that you listened. Next week is the Heart Rhythm Society meeting in Boston, and if you're there, come say hello. I'll be there speaking at a Hyde Park session on Saturday about what else? Left atrial appendage occlusion. So until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.